going to look at ventilation assessment, a breathing assessment, and how it differs in the pre-hospital environment, and the things that I really want you to be enthusiastic about doing properly once in your primary survey. It's really important to focus on what you can see, what you can count, what you can hear, what you can feel, what you can tap, and at the end of the day, how hard the patient looks like they're working, their work of breathing. As important in the adult as it is in the pediatric case in the pre-hospital environment, because it's your biggest indicator of someone who's going to have a time-critical condition. So looking at Ben here, just from my perspective, you can already pick up fast, slow, deep, shallow. So in the same fashion as we have that binary separation of unconscious or conscious, for big sick, little sick, it's important to look at this patient and say they're breathing fast and they're breathing shallow. And you can make that assessment instantly. Now, making use of a timing device, either your phone or watch, a quick respiratory rate before you do anything else. Okay, so he's breathing 22 breaths per minute. That's faster than normal and an important early marker of respiratory distress. So moving on to proper inspection, we're going to expose Ben. And Ben, don't worry, we've got a wee blanket here for you. As soon as we get you on the stretcher, that's going to be on, and I'm going to cover you back up again in a second. That brief period of discomfort is incredibly important to properly assess the chest. So looking for injuries, looking for bruising, looking for disfigurement, looking for any sign of bleeding or overt muck from the road or the scene, and looking very specifically for symmetry. So do we see equal chest expansion both sides? And looking, we do. If we didn't, we'd want to go and see if that was a permanent disfigurement or if there was a definite difference in the rise and fall on each side. So moving on from inspection, we're now going to feel that chest expansion, and at the same time we're going to apply pressure on both sides, looking for tenderness, bony crepitus, surgical emphysema. We're going to do one side at a time so that we know the side our patient grimaces on is the side where the pain is. So if we find signs of fracture or potential pneumothorax with localized subcutaneous emphysema, we can localize the side of the insult. Now, having felt around the front, we are going to, with our gloved hands, feel a little bit more posteriorly, an early check for any blood on the glove, and under direct vision, similarly on the other side. Now, moving on from palpation, it's worthwhile doing percussion. An abnormal percussion note is a significant finding. Similar to auscultation, your odds of actually having something that you can interpret in a loud outdoor environment are low, but it may be that this scene is enclosed. You're in an industrial landscape, a commercial site, or in a patient's house. So it may be that you've actually got really good conditions to pick up a difference on percussion note. So a firm tap, moving from left to right each time to compare note, to get an idea of any asymmetry whatsoever. And we're going to stop it there because with a respiratory rate, a good palpation, a good percussion, and most importantly, a good inspection of the work of breathing and the symmetry of breathing, you can make all the decisions that you need to make in terms of life-critical injury or illness. When it comes to the findings that you're going to make on auscultation, whether those be wheeze, that's audible or inaudible, crackles, audible or inaudible, and the equality of chest expansion, they may direct you in certain ways for medical therapy, but most of those things you're going to have other pointers to.